Thank you for following us, and we look forward to seeing you.
The idea behind holding these open virtual classrooms is for people to get to know us, to see our daily work, the day-to-day of our school. Now we're going to present our clinical case from our school in Córdoba, together with Professor Gemma León Bravo. It's a patient we treated jointly, and we thought it would be quite original to present it, mainly so that, first of all, you can understand what Menier syndrome is. We're going to talk about what Menier syndrome is. I'll introduce the topic, and then Professor Gemma will also speak about the treatment to help differentiate between two types of pathologies. And today's idea, those of you in the school know this well.
Hello, Gemma. How are you? Here she is to say hello.
I'm still here.
When it's your turn to speak, just tell me and I'll advance the slides for you, okay? Let's see if we can bring up the presentation. One moment. There we go. The presentation is up. I think you'll see it well. And there you see an image of the school, our school, Gemma's clinic, which has been transformed into the professor's clinic and now into our R.M.P. school for the world. It's where we work to. Let's talk about today's topic, an important one. Let me move on through the slides. I think it's an important subject, and I call it the great misunderstood. Not that the syndrome is unknown. The syndrome is very well known, but the approach is what's misunderstood. So let's start with Menier syndrome, which is quite common at times, and which, in my humble opinion, and as you know, that's a personal opinion, is very poorly approached. Why do I think so? You'll see it in the patient we're going to present. It's poorly approached because it's considered in isolation from the craniofacial system, which is so important. When this system is isolated, diagnosis is called endolymphatic hydrops, an excess of fluid within the membranous labyrinth. Start to associate, if you will, the membranous labyrinth and its relationship with the temporal mandibular joint, with the mandible. The mandible is right next to that membranous labyrinth, and no one takes it into account in diagnosis. Epidemiology tells us it generally affects 0.2 to 0.5% of the population. It's more frequent in adults between 20 and 50, though it's also sometimes seen in children and in older age. It generally affects only one ear, but in some cases it can involve both. Loss of balance, please focus on that, makes life very hard for patients. Well, the general problem is an accumulation of endolymph, which increases pressure in the labyrinth. This pressure distends the internal membranes and alters the transmission of auditory and vestibular signals. As a consequence, vertigo crises appear along with the characteristic auditory symptoms. The main symptoms, known as the classic tetrad, are recurrent vertigo, sensory neural hearing loss, which can be fluctuating, not always permanent, tinnitus, that annoying noise in the ear, and a sensation of oral fullness. This combination of symptoms guides us fairly well in diagnosis. In the initial phases, these intense vertigo crises can sometimes be disabling. Over time, hearing loss becomes more progressive and, at times, permanent. Imagine what that means for a patient's quality of life. The intervals between crises vary. Quality of life is totally affected. The patient becomes anxious and unstable. It's quite a severe syndrome for a patient's life. Diagnosis is normally, and this is where I'll lay.
Excellent. Good afternoon again, everyone. To continue the presentation, we're going to do a brief comparison with benign paroxysmal positional vertigo, BPPV. Later you can ask me any questions you have about it, because this syndrome is always, diagnostically speaking, poorly differentiated or very controversial in the medical world in relation to Menier's. So, they are two disorders which, though different, both belong to inner ear pathology and can even coexist. In fact, BPPV is usually triggered when we make head movements, whereas Menier's is an even more complex condition in which there is also hearing loss. What happens is that, as with all syndromes, some symptoms may be much more pronounced and others less so, and that's where the controversy and confusion begin in the differential diagnosis between the two. They can even coexist and one can exacerbate the other. Shall we move on, Professor? So, we'll focus now on BPPV and later, using specific clinical cases, we'll see the importance of this syndrome in parallel with Menier's. For those unfamiliar with these terms, paroxysmal refers to a sudden, acute, abrupt onset of vertigo and its appearance. It is therefore a rather unstable syndrome for the patient, provoking a strong sensation of instability and insecurity. Shall we move on? We can place it within the nervous system as a peripheral type syndrome. We know the nervous system is divided into central and peripheral. There are also mixed type syndromes. This one is peripheral due to involvement of the inner ear or the vestibular nerve, and it has an acute course. Move on. As for its main characteristics or distinguishing symptoms, it is well defined by vertigo that is positional and static, as mentioned. So, if I'm in a static position and turn my head, or change from sitting to standing, this type of vertigo begins. It's very specific and usually lasts less than a minute. It's almost always accompanied by nystagmus, which is also positional, so when I turn my head, the eye starts moving rapidly side to side, rhythmically and involuntarily, as long as the vertigo episode is active. Associated symptoms include possible cervicogenic dizziness, as well as nausea, vomiting, and instability. Of course, balance is lost, and there's significant emotional impact on the patient. On the right, in the anatomical diagram, if you can pick out the center, where we'll later focus anatomically, you'll see an area of the inner ear called the saccule and utricle. Please focus there a bit because we'll come back to it. Move on, Professor. In terms of prevalence, this vestibular syndrome represents 25% of peripheral vertigos, making it the most common. Its causes are of two types. Most often, the reason is unknown, idiopathic, which is part of why we're here today talking about R.M.P. Why idiopathic? Because in 80% of cases the causal basis isn't understood. Today we'll see a prototype of such a case, labeled idiopathic when it really wasn't. Then there are secondary causes, the other 20%, associated with trauma, accidents, brain injuries, neuritis, and Menier's disease itself, which the professor described earlier. Move on. Back to inner ear anatomy. The inner ear is responsible for both balance and hearing. We're going to locate BPPV within the vestibule. The vestibule, as I said, is anatomically represented by two structures, the saccule and utricle. They are responsible for balance when the person is at rest. What happens? We have tiny calcium deposits, little crystals, located in the saccule and utricle, and if those deposits leave those structures and pass to the adjacent anatomical structures, the semicircular canals of the inner ear, vertigo begins. The cochlea, on the other hand, is not affected in BPPV because it's responsible for hearing, though it is affected in Menier's. Move on. Pathophysiologically, BPPV is activated by the movement of otoliths/otoconia from the saccule and utricle through the semicircular canals, which causes overstimulation of the hair cells lining those canals. The movement of the otoconia occurs in the endolymphatic fluid, which mobilizes those hair cells and triggers a sensory receptor stimulus to the brain. The brain detects that motion and responds with symptoms such as nystagmus and vertigo due to overstimulation of those hair cells. Move on, Professor. Very important, before beginning any treatment, and as a foundation of our school and of good therapeutic practice, we must first evaluate by taking a proper history, studying the possible origin of the syndrome we're facing, its severity, and based on that pre-study, how we'll plan our treatment. We'll gather all possible data in the clinical history and interview, the nature of the episodes, prior trauma, their duration, etc. Other associated symptoms like nausea and instability, whether there are comorbid pathologies, and, of course, current medications, so we can study potential triggers for the symptoms our patient describes. Move on, Professor. As for treatment, if we're facing a pure BPPV, note why I say pure, standard physiotherapy includes repositioning maneuvers performed after a thorough diagnosis of which semicircular canals are affected. We can't use just any maneuver, each diagnostic finding with its specific test corresponds to a specific treatment maneuver. If we get it wrong, we might move the otoconia from one canal to another without returning them to the saccule/utricle. In addition to these maneuvers, we can add specific vestibular rehabilitation with habituation/adaptation exercises and also adjunct pharmacological treatment, similar to what the professor described. Move on. Our physiotherapy intervention proceeds through phases. First, habituation. The therapist exposes the patient to repeated maneuvers that provoke imbalance, during which the patient experiences significant dizziness and must feel safe. Then an adaptation phase with stabilization exercises, followed by strengthening towards sensory substitution/adaptation, and finally functional integration to help the patient improve activities of daily living, which have been severely disrupted. Move on, Professor. Possible complications of BPPV include persistent cases. Imagine living like that constantly, it's unbearable. We have patients like this and they have no life. They can't work, can't drive, can't be left alone at home, can't go out. Imagine it persisting and being diagnosed as such. There are also patients who, once treated and improved, experience recurrence. Another possible complication is residual instability. Many patients have a slight lingering instability after treatment. And, of course, constant anxiety, because imagine living like this. Move on, Professor. The principles of treatment include, above all, individualization. With different semicircular canals and different diagnostic maneuvers, there are many treatment maneuvers. If we don't individualize, physiotherapy won't be effective. We must also set clear objectives, where we're going and why. As we all know in our school, we need to be very clear about the causes, otherwise, treatments are in vain. Maintain a physical approach, applying the maneuvers mentioned, with the goal of returning the patient to functional life. Move on, Professor. Here we have a graphic representation of how much this syndrome affects activities of daily living. The most affected, in 80% of cases, are domestic tasks, then driving, 75%, and then work activities. Of course, patients may be unable to work. Move on, Professor. Special parallel cases, elderly patients with cervical arthrosis. It's very typical to see, alongside BPPV, cervical stiffness and a parallel vertebrobasilar artery compression syndrome with reduced cerebral blood flow, which complicates matters further. We must be clear about comorbidities to treat them simultaneously. There are also mobility limitations in cervical cases to work on in parallel. Another specific case is bilateral BPPV, occurring in both ears, which must also be addressed bilaterally. And, as mentioned, recurrent BPPV, which returns after supposed resolution. Move on, Professor. When BPPV occurs in multiple semicircular canals, we must diagnose it as such and treat all involved canals in parallel but by priority order. Identify the most affected canal, start there, then sequentially treat the others. As you can see, this is a fairly complex diagnosis requiring study and preparation. Multi-canal involvement often follows accidents or head trauma.
We wanted you to see how, in a real patient we treated together, holistic diagnosis is often forgotten in these pathologies. We look at the ear. Of course the ear is involved and must be treated locally, because the patient can't live otherwise, no doubt about that. But what happens if we forget the rest? It's not only the ear that's affected. In chronic patients like this, a series of circumstances has also led to dysfunction of the auditory system. And unfortunately, this isn't considered in healthcare. So we'll share the case for you to see. This is a roughly 75-year-old patient.
Well, the patient had been in treatment, but as the professor said, it wasn't effective and he came in still with vertigo and nystagmus. In our tests, when changing head position, nystagmus appeared. He had generalized arthrosis, as is common, throughout the spine, and tests for vertebrobasilar artery compression were positive. With significant cervical arthrosis, there was segmental blocking and lack of mobility at the craniocervical junction. We also observed sphenobasilar dysfunction and, given symptoms in tests, involvement of the vagus nerve. Posturally, as we'll see, the patient had a significant loss of cervical lordosis. Functionally, he could never be alone because anxiety and muscle tension increased, creating a vicious cycle that worsened the syndrome. While analyzing him, we requested he be accompanied in daily activities to stay as calm as possible. Move on, Professor? For treatment, we began applying our physiotherapy and osteopathic techniques, but as we said, before any treatment we ran many diagnostic tests. We were dealing with BPPV, plus cervical vertebrobasilar compression, and of course, in our school we cannot ignore the state of the mouth to see its cranial impact. So, in parallel, we decided to proceed with a multidisciplinary R.M.P evaluation with the professor. The professor will now comment on the process we undertook together, and I'll outline the physiotherapy side. We performed cranial base decompression with osteopathic technique, changed the straightened cervical lordosis, did craniosacral therapy because there were cranial restrictions at the parietals, sphenoid, and in fronto-occipital motion. There was also altered dural mobility at the meninges. We mobilized articular blocks from C3 to C6 bilaterally, and due to the time course there was a constant protective muscle pattern in the suboccipitals and sternocleidomastoids, among other muscles, for which we used neuromodulation to deprogram both chronic tactile pain and constant contraction sent from the CNS. Later we worked posturally in the final phases to change the kyphotic attitude, correct the straightening, and start an uprighting process, but that's already in the last phases, after the treatments the professor will describe. We included global exercises for vestibular re-equilibration and strengthening for arthrosis protection. We treated BPPV with its specific maneuvers, and we'll discuss the cross-system disorders we found. Whenever you're ready, Professor.
To carry out, as we say, truly interdisciplinary therapy, which we apply every day with Gemma and her team at the clinic. I'm fortunate to work with them. We work together and can implement R.M.P 100%. We're all together. Obviously, when a patient arrives with dizziness and so on, R.M.P says crisis management first. You can't immediately apply the general R.M.P protocol. You do crisis treatment to reduce symptoms so the patient improves, and then you can apply the curative R.M.P treatment. So you see the posture. We begin analyzing posture. As we said, kyphotic attitude, a patient with two different profiles, cervical locks, lumbar and foot locks, and obviously we began to look beyond the ear. We also looked beyond the eye problem. A 75-year-old patient arrives at the end stage, and you'll see this could have been prevented long before if a holistic, interdisciplinary view had been used. Let me explain why. If you look at the foot, it's severely traumatized. Hallux valgus. No proper stability. This problem has been present for a long time. That's why in our school we insist so much on prevention during growth. That's when you avoid this, not when someone reaches 75 and suffers. The forefoot is the same. Instability. So we have a foot that doesn't function, bilateral hypoconvergence of the eyes, and then what I consider the catastrophe, the mouth. We don't take it into account. There is a loss of vertical dimension, a catastrophic rehabilitation outcome. Chronically, mandibular retro with no sway. All of this chronically leads to a series of dysfunctions and eventually a general bodily dysfunction. There isn't much torsion with the mouth. But if you look at the green, it is still posterior. That indicates a mandibular retroposition. Diagnostically, we say mandibular retroposition with loss of vertical dimension. This is a catastrophe orally. Imagine chronically how this compresses, not to mention dental rehabilitation, speaking strictly about mandibular position. A mandible with loss of vertical dimension and a posterior position compresses the middle ear, which will affect the semicircular canals and chronically, not immediately, cause issues. Medicine doesn't take this into account, unfortunately. So, using the body
Mandible with loss of vertical dimension and a posterior position compresses the middle ear, which will affect the semicircular canals and, chronically, not immediately, cause issues. Medicine doesn't take this into account, unfortunately.
So using the body equilibrium device, we neutralized the mouth. We didn't treat the mouth, we neutralized it. Increased vertical dimension, slightly repositioned the mandible. We did physiotherapy, as the professor said, and osteopathy. And it improved immediately. After neutralizing the mouth, all symptoms began to improve, and after a week, all symptoms subsided, and the patient has been stable for 5 months. We continue to monitor these patients. So the combination...
Gemma, congratulations. Great presentation, as always, and as always, a lovely interdisciplinary effort. I enjoy working with you, I really do. We apply R.M.P. 100%. Her whole team...
Thank you for following us.